Hello and welcome to our Menopause 101, a comprehensive overview webinar. We'd like to thank you so much for taking the time out of your busy schedules to join us today. This is actually the first of our monthly series that we will be hosting this year, and we are so excited to launch this series that is brought to you by Positive Health with this terrific overview that will be presented by Dr. Monica Leff. My name is Kim Fancher, and I will be your host today. And I do have a few housekeeping items to share with you. You may have noticed when you signed on to Zoom that your audio was muted, and we ask that you keep your audio muted and video off so that we can provide an uninterrupted experience for all. Also, we anticipate that you may have some questions for Dr. Leff, so we ask that you please type in your questions in the chat instead of unmuting your lines. As your host, I'll be monitoring the chat, and at the end of her presentation, I will share with Dr. Leff all your questions that you have provided, and she can then provide a response. We believe we've carved out plenty of time to answer and address all your questions. So, please don't be shy in submitting them here in the chat. There's also a show captions feature with the Zoom app. So if you feel you'd like to have that turned on, please do so. And we want to let you know that this webinar will be recorded so that we can make it available for others to view on demand. So now I'd like to introduce you to Dr. Monica Leff. Dr. Leff is a gynecologist and menopausal medicine specialist. She graduated from the UCLA School of Medicine and did her residency in OBGYN at Harbor UCLA Medical Center. She has practiced in Long Beach, California for 40 years and is the chief of staff for Miller Children's and Women's Hospital, Long Beach. Thank you so much, Dr. Leff, for kicking us off with this Positive Health webinar series today. And with that, I will pass it on to you.
Well, thank you so much. I want to thank Dr. Edwards for this opportunity to talk about my favorite subject. And thanks to you, Kim Fancher, for all the tech help and helping us get this Zoom and webinar up and running. Kim mentioned I've been in practice for 40 years, and it's been one of the most rewarding parts of my practice is to partner with women during their menopause transition. So let's pull up the next slide, which is our agenda. So who are we? There's been what is menopause? Who are we? What are the demographics? I'm going to cover perimenopause as something distinct from actual menopause. When is lab testing helpful? Talk about the common symptoms, and then our most current treatments. There's been a lot of discussion about planning for menopause, and I think there's just great information. In the past year, the discussion about menopause has really skyrocketed, and there's much better information available. But I want to emphasize for each woman is that you have to allow your own process. Who, what, when, where, and why. For me, it's the why. My very first patient in private practice came to me for help with menopause, and she described a huge constellation of symptoms, and all I had been taught about was hot flashes. So I'm just so grateful. I just started listening, and my patients have taught me how to do this. I want to emphasize that for each woman, it's an individual calculation of what she feels and what she wants to explore. We're doing it better. The good news here is that there's so much available that is safe and not expensive. We're in a space where Lots of products are being marketed. Lots of women will go through this and not need a prescription, and they'll be fine. But a number of women are very, very impacted, and really for a huge percentage of women, the benefits of a trial of hormone replacement really do outweigh the risks. Lifestyle and nutrition have huge impact on this. It is amazing the variety of products and dosing that could be the right fit for an individual. We've been doing this for a very long time, and I will speak about the WHI, which really led a lot of people to mistrust us. The most amazing part of my experience in treating menopause is then when we get it right, almost as if on script, all my patients come back and say, I feel like myself. If you've had a hysterectomy, the choice is almost easier without having to consider the downsides of progestogen replacement. But the true fact is that most of the symptoms related to menopause are related to absolute estrogen deficiency. Next slide. So menopause is normal. All of us go through it. Some of us go through it surgically, but our traditional definition is no menstrual period for a year. And what this means is that the ovaries have just stopped producing estrogen and ovulation has ceased. Some women do experience this prematurely. A lot of that can be genetic. It's curious to me that our medical recommendations is absolute treatment for every woman undergoing premature menopause, but natural menopause could be so much more controversial. We like to point out that many of us will spend 40% of our lives in the menopause space. I find the term postmenopausal can be misleading because unless you are on replacement, you will remain estrogen deficient. Many symptoms can abate without treatment, but estrogen deficiency is for the rest of your life. Next slide. Can we go back to the one that says transition? Yeah, there we go. So there's a period of time leading up to menopause, which has been commonly called perimenopause. I like to use the word transition because they sound so similar, and a lot of the symptoms are similar, but hormonally what's going on is really completely different. And the treatment, if perimenopause is causing lots of symptoms, would be different. So very frequently the periods change. A lot of the premenopausal symptoms such as PMS, cravings, mood changes, and hot flashes become much more marked in the premenstrual period. Breast tenderness can become very unpredictable and unrelated to where you are in your cycle. Ovulation for sure is less predictable. And during this time, there's a marked increase in the events of abnormal bleeding, which I'm going to talk about in a minute, that needs to be evaluated. For many women, if we just explain to them the physiology, they go, oh, okay, now I understand what's going on. I'm fine. Next slide. So what happens in perimenopause is that ovulation is less predictable, and then the regular monthly changes in estrogen and then progesterone start to become very inconsistent. I like to explain, I think of this as higher highs and lower lows that produce dramatic rises and falls, and it's the dramatic fall that trigger hormone withdrawal symptoms such as hot flashes. And that's why it feels similar to menopause, but what's going on with your blood levels is very different. Many women complain of worsening of PMS with the physical symptoms of bloating and headaches and breast tenderness. Next slide. So abnormal bleeding is defined as a period that lasts longer than 7 days, or a cycle length that is shorter than 21 days, or bleeding that is in between periods. Postmenopausal bleeding is any bleeding that occurs greater than 1 year after the previous period. The real point of this slide is to emphasize that abnormal bleeding needs to be evaluated. Sometimes there can be anatomic issues. Often it's a hormonal glitch. But during this time where ovulation is less predictable, overgrowth of the uterine lining can manifest, which, if neglected, can lead to uterine cancer. Uterine cancer is the only cancer where mortality has increased because people have become just too casual about this. Next slide. So lab testing, lots of women experiencing increased PMS come in thinking they need to have their hormones checked. And thyroid disorders are very common in women, and we should always consider checking for that. But for a woman who is having periods, checking for FSH, follicle stimulating hormone, and estradiol, which is the main estrogen produced by the ovary, varies so much that a random blood test really is not helpful. After periods start spacing out, testing can be very useful if a woman needs to know if she's at risk for pregnancy. The testing is really not necessary if there is no risk for pregnancy, and our decision to recommend a treatment is not based on the numbers, but on the quality of life as we make decisions together. The actual numbers actually don't correlate with the severity of the symptoms that an individual would experience, and it's really about the conversation of how bothered or not you are that would lead to us to make a recommendation. But finally, for someone who is in menopause on treatment, getting blood tests can be very useful if you're just not responding. There's a wide variation on how women absorb medications, either orally or through their skin. And some women actually have a much higher liver metabolism, often because they may be on a lot of other medications and their liver enzymes have been induced. I want you to be aware that there are clinics who take advantage of women, so avoid places that require routine large lab panels every 3 to 6 months. Next. So cannot possibly discuss menopause with talking about the Women's Health Initiative. This was a well-intentioned study that was theoretically designed, excuse me, to show that estrogen is good for blood vessels. And actually it is. Excuse me. This study used an oral estrogen and a synthetic progesterone, which is very commonly used. Excuse me, just a little dry this morning. And the results were released to huge publicity because the study was design was released early because there was a finding of a small increase in the risk of breast cancer on women who were taking the combination product. Our phones were ringing off the hook. It was July. Part of the problem with the study design is that most women were a good 10 years after their last period when this was initiated. So you can't show prevention to the cardiovascular system when you've already waited 10 years to attempt to help. The product they used had a synthetic form of progesterone, which we've known for a long time increased the risk of breast cancer in other mammals. The total increase in breast cancer, however, was found to be small. And interestingly, in the arm of the study that showed women taking estrogen only, there was actually less breast cancer. Next slide. So here are some of the most common symptoms of menopause. I talk to patients about 10 symptoms because I can count them on my fingers. So hot flashes, night sweats, insomnia, mood change, memory change, joint aches, decreased sexual desire, decreased sexual response, vaginal dryness, and pain with sex happen later. And they're also the symptoms that are the slowest to resolve if we do initiate treatment. Some women often will say to me that they don't know if they're having a hot flash. They will describe warmth that they think is insignificant because it's not miserable. And again, I just go back to everybody experiences this differently. Next slide. So hot flash, we call the constellation of hot flashes, night sweats, and palpitations vasomotor symptoms. These symptoms are the most reliable indicators of the onset of menopause, and they affect 60 to 80% of women at some point. Vasomotor symptoms can last for months or years or decades. And as you see below, it does vary by racial group, with Black women experiencing more than Hispanic, more than Caucasian, more than Chinese, more than Japanese. Next slide. So I like to call out the difference between hot flashes and night sweats. They really are virtually the same thing, except some women just don't experience hot flashes during the day. But night sweats are very often much more severe than hot flashes. And some women can question whether they are in menopause if they don't have daytime hot flashes. Night sweats very often disrupt sleep and also frequently lead to cold sweats from throwing off the bed covers as you become sweaty during the night. Next slide. So, hot flashes, night sweats, these have been studied for a very long time, absolutely cause sleep disturbance. They are very much correlated with an increased incidence of depression or mood disorder and affect brain function. And we've seen clear indications of a link between women experiencing hot flashes and increased risk for cardiovascular problems and poor bone health. And we all know this. Next slide. So insomnia is probably the most disruptive symptom of all. And this is often the biggest reason that women may want to explore what their medication options are. It's been demonstrated that sleep quality is really affected whether women sense hot flashes or night sweats. Obviously, we all know sleep disturbance is associated with increased daytime fatigue, irritability, increased risk for other chronic diseases and mood problems. I'll call out specifically that our most common progesterone that we use now, which is oral micronized progesterone, is associated with improved sleep. And it's very often that we will play with the doses of that to help the symptom. Next slide. So brain fog is real, and women are tired of being told that this is not real. Early in my practice, I had a 37-year-old engineer with premature menopause. She was a widow with 2 young sons, and her only symptom of menopause is that she started getting lost in her neighborhood. Estrogen replacement completely solved that memory issue, and you can imagine as an engineer, she found this symptom even more distressing. Word finding, brain fog, confusion often are helped with hormone replacement. Of course, we understand that there can be other reasons for this, and so check in with the doc really is useful as you navigate this. Next slide. So depression and anxiety are clearly associated with the menopause transition, and this can be dramatic and it affects relationships. It's important to acknowledge this, as this affects someone's total quality of life. It does seem to correlate. I've seen this, is that women who've had a significant history of PMS seem more susceptible, also for women who've had a history of postpartum depression. And when you think about it, the postpartum state is just like menopause. Your estrogen and progesterone levels just go to zero. Some women come in actually completely rageful. Some have their reasons for it, but for many, this have been completely out of their character, and is another reason why women seek help. Next slide. So joint pain, which is also called arthralgia, actually has been only more recently recognized, but absolutely there are women who will notice pain in their joints, knees, hands, hips, that is absolutely responsive to estrogen. Now, there are, as women age, there is greater onset of other forms of arthritis, the poorly defined syndromes of fibromyalgia, and that needs to be looked at. And there are medications women could be on that also cause joint ache. So again, careful evaluation for multiple causes. It's no question exercise, use of Tylenol can be appropriate. But this can be a driving symptom for treatment as well. Next slide. So loss of libido is extremely common and often associated with distress. Sex is a huge factor in human happiness and unhappiness, and we need to talk about this. Next slide. So somebody who's been listening to patients for 40 years, excuse me, sexuality is a really important component of quality of life and the human experience. Most women remain under-evaluated and under-treated. They are shy to bring this up to their doctors, and their doctors are often shy to ask about it. Huge percentage of women do report some sexual dysfunction. While this slide suggests that 12% of women find this stressful, my experience is that it seems a lot higher than that. But of course, the population I am seeing are people who are seeking help. Sex is good for you when you want it. So being able to facilitate this is good for relationships, and it's good for your sense of well-being. Next slide. So on the spectrum of manifestation of estrogen deficiency, super common is vaginal dryness, and that may only need the right kind of lubricant. When left untreated, it often can be progressive and lead to just frank pain with penetration. Treatment is super easy. Topical hormone treatments, of which there are many types available, are not systemic. And so they confer virtually no risk other than what it might cost you. It's really hard to work on issues of desire if sex is painful. In addition, topical local estrogen to the vaginal and vulvar area is really helpful for preventing UTIs in women who are having an issue with recurrence. Talked about the value of maintaining sexual intimacy. We've talked about how common this is, and I think we've got this. I think we've got this one covered. Next slide. So just to emphasize what the low-dose vaginal products are and how safe they are. In fact, they're so safe, we are often recommending it to patients who have this local symptom, who have breast cancer. And the Menopause Society has been lobbying the FDA to take off the usual warnings off those labels, which are meant to give information for systemic estrogen. The most common treatment is a vaginal cream, but there are also vaginal tablets and a very user-friendly vaginal ring for those women who want to pursue that. We can usually see improvement in the symptom in a few weeks, with the full range of benefits seen usually within a couple of months. We've done blood testing on these patients. There's no rise in their serum estrogen levels. And again, to emphasize, not systemic. Next slide. So weight gain, this has been really controversial area. And as we're greater and greater understanding the mechanisms of estrogen deficiency, we are starting to talk about the association of weight gain at midlife, which our patients have been telling us about for decades, that people start to gain weight in the middle. So what's happening at the same time of menopause is a change of metabolism related to aging and some lifestyle choices. There's no question that fat starts to redistribute. Often this could be accompanied by loss of muscle as well. That central fat increases the risk for insulin risk, increasing the risk for diabetes. Now, hormone replacement is not a specific remedy for this, but if there's overall improved well-being, then perhaps there's better motivation for lifestyle modification. There was just data released earlier this week that there seems to be some information that women on hormone replacement are more responsive to our newer GLP-1 diabetes medications that are now being used for weight loss. Next slide. So there's been a lot of discussion over the years about changes to skin. There is a benefit to estrogen to skin, but we seldom market estrogen, systemic estrogen replacement for this specific indication. But many of my older patients are absolutely convinced that this is what they get. Next slide. So, great time for us to just take a second, review how we decide, how patients decide, how we have shared decision-making on who wants treatment, what are hormonal products, non-hormonal products, what are other potential benefits, some of our fears about this, and how to do it. Next slide. So I love this part of the discussion where I get to sit one-on-one with the patient and we talk about what she's experiencing, what her goals are, what her personal health history is, what her family risk factors are, and how she wants to proceed in terms of what her individual symptoms are. I just want to emphasize again that a decision to try something is not based on your estrogen level. I also love to emphasize to my patients that at our first discussion, it's not their very last chance. They've got quite a while to absorb this and figure out, what are they feeling? Is it getting worse? Is it getting better? And it can take months or even years for what the short-term and long-term goals are. So there's no urgency to start. However, patients who do come in with severe mood disruption, I often will advocate that they give something a try because these women are experiencing distress. Next slide. So hormones. It's kind of sad. Ever since the WHI medical schools are mainly teaching that lowest dose possible for the shortest period of time. Our nomenclature, most recently, we've changed things to call it to say HT, which is hormone treatment, or MHT, menopausal hormonal treatment. In this slide, we will talk about estrogen and progesterones. Our old term of HRT is something I still favor because HRT means hormone replacement. And I like to emphasize that we are replacing a molecule that is known to the body, and the body knows how to metabolize. And it is the estrogen component that will solve most of the menopausal symptoms. If you've had a hysterectomy, you don't really need to consider taking progesterone because progesterone is added to protect the lining of the uterus. Estrogen by itself over a very long period of time can cause overgrowth of the uterine lining, which if neglected can lead to a serious precancer or actual precancer, but that takes a long time and often has warning symptoms. So estrogen products, we have creams, we have tablets, we have estrogen patches, my favorite, and we have vaginal rings, which are very convenient, but also very expensive. They're the most, probably the oldest product on the market is Permin, which is conjugated equine horse estrogen. It's many different molecules. Sounds strange. It is an effective treatment, and there's a lot of data involving its use. The synthetic estrogen, ethinyl estradiol, is available in birth control pills, and so that's available mainly for treating premenopause, either orally or actually as a contraceptive vaginal ring. So progestogens is meant to encompass either natural progesterones or synthetics. This is a hormone that women might have side effects to, and it can, in a small number of patients, really affect their mood adversely. Natural progesterone, which is oral micronized progesterone, is our most popular progestin, and this is often because we think that this is safer for the breast. Sounds great that we should be replacing the same progesterone that the ovaries were making. Many clinics advocate for using skin cream, but we have no studies showing good enough absorption so that it will protect the uterus, so we tend to shy away from this. Now, for women who have bleeding issues, some of the synthetics do work a lot better. Provera, medroxyprogesterone acetate, is the synthetic progesterone that was in the WHI, so I like to stay away from that. Norethindrone acetate is the synthetic progesterone in a lot of birth control pills, but has very strong action on the uterine lining and discourages abnormal bleeding complications. Levonorgestrel, another type of synthetic progesterone, is available in birth control pills, but also in the medicated IUD. And drospirenone, which is a really cool, different synthetic progesterone, which has similarity to a water pill. It has become more popular. It's very mood friendly and discourages acne. So not in the United States, but in Europe, we have used the IUD as the progesterone component for hormone replacement. Benefit of that is that it's not really systemic, so theoretically no effect on the breast. Does need to be changed every 4 years. Next slide. So the point of this slide is there are other theoretical benefits, long-term health concerns that hormone replacement can affect. There is robust data that for women in their 50s, starting hormone replacement within a short time of their onset of menopause, that there's a 50% reduction in cardiovascular disease and cardiovascular death during their 50s. We're still waiting for data to confirm that continuation of this extends into the 60s and 70s. It's not really there yet, and the cardiology community is not so much on board with this yet. Absolutely, estrogen protects the bones. The best thing you can do for your bones is take estrogen. A lot of the osteoporosis medications come in after the fact and have unusual sticky absorption, stay in the body for a long time. There's controversy with those drugs as well, but there's been less public controversy compared to estrogen. Data from the WHI showed a reduced risk of colon cancer. WHI also showed increased risk of dementia, which has been shown to be only related to the delayed onset of starting estrogen 10 years after the menopause. There's excellent data now that estrogen is great for the brain. Estrogen affects all the tissues of our body. It is, however, not the fountain of youth. We're not going to live forever. But too many very symptomatic women have just been terrified to try. And honestly, it's not being well taught, even in OBGYN residency. And it's just easier for doctors to say no when they think that there's a risk of being sued. Next slide. I'd like to call out this special formulation, which has been out for about 8-9 years in the United States. And it's called Duovi, which is a combination of Premarin, that horse estrogen, without progesterone. It's with a medication called a SERM, which is selective estrogen receptor modulator. Now, that's a really confusing term because it sounds like estrogen, but it's not. The most widely known SERM is the drug tamoxifen, which is used for preventing and treating breast cancer. So these drugs act on different kinds of estrogen receptors in different tissues in the body. This particular SERM, called basodoxifene, which is only available in the United States in this combination, has been shown to be extremely favorable to breast health. Biopsies show that the breast just does not proliferate while this medication. It also has extremely low rates of bleeding. It's been approved for prevention of osteoporosis. And this is a great drug for people who have a bigger concern about their risk for breast cancer. Next slide. So, bioidentical hormones. We're all hearing about that. This term was made very popular by the celebrity Suzanne Summers, who was an advocate for hormone replacement. Now, what this word should mean is that we're replacing the same hormones that the ovaries were making. And we do this. This is how we start. But this has really become a marketing term. And there's been a community of clinics, partly because women weren't getting help, but who have advocated that these medications are safer. These are the exact same molecules that you can get in a generic prescription from your local pharmacy. They're not FDA approved. I think most of these products are safe. The problem with the FDA approval is that there's been a lack of standardization, which means the potency can vary tremendously from pharmacy to pharmacy or batch to batch. Next slide. So testosterone there's no formulations that are FDA approved, but there is wide data that tells us how for some women, testosterone is incredibly important for their sexual function. Testosterone levels do drop during perimenopause and menopause. And our most common reasons for recommending testosterone are for low libido or diminished sexual response. These have been shown to be safe. There's been real challenges with FDA in analyzing the benefits. I'd like to emphasize you don't need a blood test proving low testosterone to try this. Certain subset of doctors are comfortable prescribing this because it does require logging on to state databases. Testosterone is a controlled substance, which in very high doses has been abused by bodybuilders and athletes, but it's been safe. And everything is really, the safety for this and response is about dosing. Many women are responsive to this, but not all. Some women are just testosterone non-responders. Next slide. So there are a number of women who, based on their baseline medical state, have to avoid hormone replacement or just choose to avoid hormone replacement. And there are medications that are definitely helpful for hot flashes. The two most widely known, one is paroxetine, which is under the brand name Brisdell. This is an antidepressant that's been around for a really long time. Some women do really well with this one. There's a brand new one called Veoza, and this is completely non-hormonal, and this acts on brain receptors that trigger hot flashes, and that is where hot flashes come from, our brains. And in an effort to help our patients, we've been using other kinds of antidepressants, either SSRIs or SNRIs, such as Effexor, for a long time with clear benefit. This is most commonly tried in breast cancer patients. Gabapentin has been shown to have some benefit. Clonidine and oxybutynin really have been used, not nearly as effective. Next slide. So, non-prescription therapies. Many women prefer to try something that is non-pharmacologic to start with. There is data that cognitive behavior therapy, hypnosis, acupuncture, some women find useful. Really don't want to underestimate the value of exercise, especially for mood and anxiety. Women in menopause need to think about aerobic and weight-bearing exercise to help our muscles. There are some soy derivatives that have been recommended for a really long time, but there are some newer products available that have actually have some potent data. Newest one out is called Equel. And there's a lot of science behind these, where these have been modified to hit the difference between alpha and beta estrogen receptors. So our latest ones, which may theoretically or safer hit the beta receptors, which are particularly beneficial for mood, hot flashes, vaginal health, sleep, and bone protection, and avoiding the areas of bigger concern, which are the breast, the uterine lining, and liver enzyme activation for coagulation factors. So there's been huge outcry in the menopause community over the past week over a Lancet article, which is advocating mainly for cognitive behavioral therapy. We've been accused of over-medicalizing menopause. And while the menopause community, we appreciate all the options that we can explore with our patients, but we are really kind of resent describing physical symptoms, often related to thermoregulatory areas in the brain and bone physiology, as framed as psychological. We feel that this is gaslighting women, and menopause community is having a huge response to this Lancet article this week. Next slide. So the cardiology community acknowledges some of the benefits of estrogen on vascular health. We think we think estrogen could be the reason why women live longer than men. But overall cardiovascular disease is the leading cause of death in women. And we're really attempting to prove more what the science is. It is a lecture I was at this week showed that LDL, the LDL, which is the bad cholesterol, increases it within 6 months of menopause, and HDL, which is the good cholesterol, decreases. We know that the LDL is considered causal of cardiovascular disease. There's been a lot of controversy that women don't present the same way with heart attacks, but the cardiology community has been looking at this more recently, and it's just been determined that the symptoms really aren't all that different. We're just blown off more, and so we just don't get the same number of studies. We're not recommending hormone replacement as primary prevention for coronary artery disease, but the data shows that it probably is beneficial. This does not apply to women who already have an existing diagnosis. Next slide. So breast cancer gets a lot of attention, as it should. 11% of women are diagnosed with breast cancer, but only 4% die of their disease. We're doing better and better with our treatments and our abilities to reduce risk with genetic testing and using screening tools such as the Tyrer-Cuzick score about how we can detect this earlier and earlier. It is critical for us to understand that breast cancer is many kinds of diseases, not one. So often when women discuss their friend or themselves as having a breast cancer that has been noted to be positive for estrogen receptor status, they describe this as estrogen having cause, but this is not the case. Estrogen receptor status is a good prognostic factor. For those women who test negative for the estrogen receptor, we absolutely can consider hormone replacement if they're extremely symptomatic. It was the WHI stopping their study early, their unbalanced discussion of the absolute risks for breast cancer that have led so many women to be terrified to try hormone replacement, even if they're very symptomatic. Okay, next slide. Okay, so I'll talk about our most common methods of giving estrogen are either with a tablet, which actually has been shown to have some good benefit for good cholesterol, but medication that is swallowed is absorbed from the stomach directly into the liver circulation. So there can be seen a small increase in the risk of blood clots, mainly for women who already have a genetic predisposition. I like to remind people that the greatest risk factor for blood clots is pregnancy and birth control pills, and the absolute risks with hormone replacement are much less. But because of this, gynecologists love to give estrogen through the skin, and this could be available as a skin patch. Holding it up, I know you can't see it very well. There are gels, creams, there's actually a vaginal ring. And by just having the estrogen released into the normal circulation as the ovaries had done, we avoid going to the liver. But even more importantly, you have a much more even level day to day rather than absorbing, metabolizing, metabolizing. It's absorbed into the skin, into the fat, and it's time release. it has less of an effect on libido, and there's really not a worry of skin to skin transfer, mainly, and this is relevant for children with estrogen, particularly with patches. Our real concern about skin transfer has been with testosterone prescription. So that's why placement is so critical. Next slide. So there's really kind of two ways to give this. And the most popular way is the second one on your slide, which we call continuous combined, where you basically have a daily estrogen, which could be a twice a week skin patch, a once a week skin patch, and daily oral progesterone, usually starting with natural progesterone. So why the other method is called cyclic, where you're on estrogen all the time, that we cycle you on and off of progesterone, usually to trigger a period. It's not really a period, it's hormone withdrawal. So most women would go, well, I want continuous combined, I don't want to bleed. The main reason for cyclic is that if you are close to your last period, if you go on continuous combined, you're going to bleed on and off all the time, unpredictably. And it's really inconvenient, it's annoying, and will trigger also a lot of interventions to figure out why you're bleeding, even though often it is the way that you're taking the progesterone.
Hey, Dr. Leff, we're about
Yes.
2 minutes left in our time. I was wondering if we could maybe open up for some questions from our audience.
You know, we're basically towards the end. I would love to have questions.
Okay. So since we have a small group today, if you have any questions, if you want to just unmute yourself and ask Dr. Leff, or if you prefer, you can add your question in the chat and I will relay that to her. So Dr. Edwards has a very good question. I'm sure it's on the minds of many. What type of questions should a woman be asking?
Well, one of the most common questions I get is, how long should I consider, if I'm going to go on hormonal replacement, how long will I do that? And I'd like to tell them that we don't have to make a decision when we initiate treatment. And it's going to be all about how responsive are you? What kind of side effects are you having? Sometimes it's how expensive are the products. But it really is all about how much benefit do I perceive. And so some women may choose to do this for a couple of years. For women who are experiencing a lot of benefit, I do personally like to try lowering their estrogen doses a little bit as an exploration at landmark birthdays, so at the 0s and the 5s. Some women come and say, I am fine, do you leave me alone? And other people say, yeah, let's see if I get by with less. And it really is 50-50. Some women, we've determined the right formulation for them. I like to call it the right cocktail. And other women find that their estrogen need, and this is very common, does decline as they get a little older and they don't need as much.
Okay, thank you so much for that. We have another question that came in. Best ways to broach the subject of sexual issues with their provider?
Oh, this is a great question. And
right?
I'm sorry?
I said being honest with your provider is a great way to start.
Well, being honest and honestly, but you know, it should be part of an intake history and physical to ask people if they have any sexual concerns. And there are some people who are, so I ask all my patients, and there's probably a more elegant way to ask than the way I do. There are most gynecologists should be very comfortable discussing this. We're in the vagina business, but some primary cares either feel busy or personally are not that comfortable. So I do suggest starting with GYN. best care should be that ask should come from the doctor on an intake questionnaire.
Yeah.
Not on a written questionnaire, talking face to face. And that's how you demonstrate that you're comfortable having the conversation.
Another question, what is the difference between HRT and birth control that includes progesterone and estrogen?
Oh, great question. I love this. So relatively speaking, the doses of synthetic hormones that are required to suppress ovulation for birth control are much, much higher than what someone needs as a replacement dose. So that's really the biggest difference is, and that also that the hormones that are used in birth control pills are synthetic. Ethinyl estradiol is by far the most common synthetic estrogen used in birth control pills. And frankly, I don't think it treats the menopausal symptoms nearly as well. Birth control pills are, however, very useful for severe transition perimenopause because it is useful to shut down that irregular ovulation during that interval.
One more question, if we can sneak it in here.
Sure.
Have you had patients, women with a complaint about cold flashes in their changes and changes in their body odor? Cold flashes and changes in body odor.
So the cold, I think the cold flashes are related to hot flashes, and there's really a dysregulation of thermoregulation in the brain. I mean, I think the sweats provoke a cold response. But again, back to we need to be checking thyroid, since thyroid abnormality, low thyroid, so common in women. I have had women complain of changes in body odor, and best recommendation for that has been talking about what areas of the body are symptomatic, antibacterial soaps for under the arms, and what kind of deodorant options they can use.
Okay. Well, thank you very much. If we can bring up the slides one more time, I'd like to wrap up with some additional information I'd like to share with the audience. And while we're bringing those slides up, I want to thank you so much, Dr. Leff, for this great overview. So much covered here, from terminology to symptoms to the latest in treatments, and we really appreciate you sharing all that wonderful knowledge with us today.
It's my pleasure.
So this is the first of many menopause webinars, and we hope that you can join us for more in the future. And we here at Positive Health are leveraging the power of webinars and podcasts to help build awareness on these many important menopause-related topics. So coming up, we do have a variety of webinars that are scheduled. One more this month here, next Wednesday. It's on mindfulness in menopause, specifically, helping out with hot flashes, and there will be an actual mindfulness practice included in that webinar session. And then in April, we actually have 2 more webinars coming up. One focused on menopause and osteoporosis, and another one that dives even deeper into HRT and the mystery behind that. So please feel free to go out to the positivehealth.com/webinars site, and you'll be able to enroll in those webinars or find them in the newsletters that you'll be receiving monthly. Also, I want to mention our podcast series. We've already released a couple episodes, and Dr. Colette Edwards, founder of Positive Health, has provided an amazing amount of information in the initial podcast episode where she talks about her passion, how she got started on this journey of sharing out information, trying to help those with their menopause journey. Then next month, we've got some new ones, and we'll be releasing new episodes the first Wednesday of every month. And you can find those at positivehealth.com/podcast. or also in your newsletter, we'll be promoting those. So I'd like to thank you again, Dr. Leff, and thank all those who attended today, and I hope you all have a wonderful Wednesday.